This is SCALATE, which stands for Sickle Cell Across Lived and Treatment Experiences, and we get to hit both of those tonight. This whole HB 107, the Texas Registry, inviting people to understand. Uh, I mean, I'm just assuming that if I didn't know, I'm just gonna assume that other people didn't know or didn't understand. But what we want is to empower our listeners, and we have listeners tonight as well as listeners that will log back on to our YouTube, where we, upload this recording after tonight to learn about the registry, to learn what they can actually do to be empowered or have impact. So with that, I'll just say, as the director of the As One Foundation, my responsibility is to forge forward with the mission to empower families globally, delivering life-saving sickle cell education. And this is certainly doing that. So without further ado, am I turning it over to you, Victoria?
Yeah, that
Okay.
sounds great. Seems that I'm not able to share my screen.
Oh,
I can
Yeah.
share my screen, Victoria, if you want.
Oh, yeah. Either way is
Yeah.
fine. hmm
Let me see if I can go ahead and share my screen here.
it's giving me a hand.
Share. There we go. Host disabled screen sharing is what it says for me.
I
hmm
am trying to give you, but my cursor has turned into a hand for some reason.
Oh,
Let me
Taking
just
a
try
life
to,
on its own.
yeah. Okay, there we go. So make host. Okay. Okay. Santosh, you are co-host, and it just doesn't want to let you be a co-host, Victoria.
That's okay. Maybe Prashant.
maybe, yeah, if you could make me a
hmm
co-host, that would be awesome.
Okay. What is this? I did give it to you, Santosh. Was that not supposed to be it was supposed to be
Not.
Prashant.
hmm
Yes.
Let me see if I could do it this way. Okay, make co-host. Okay, how about that?
Awesome. I can see
Okay,
it. Yay.
awesome,
Thank you.
awesome.
Okay, great.
All right, let me go ahead and share the screen. We'll go all the way to the top and we will start presenting. Okay. Can you see my screen?
Yes.
See
Thank
your
you so much,
screen?
Awesome.
Prashant. Thank you.
Yes, you're so welcome.
Mhm.
Go ahead,
So,
Victoria.
yeah, well, good evening, everyone. We are very happy to share this space with you today, and we're excited to continue our initial introduction to the upcoming Texas Sickle Cell Disease Registry. Before we start, I'd like to introduce our team on the call today. My name is Victoria Salinas, and I'm a medical research specialist with the Texas Department of State Health Services. I help support the ongoing sickle cell data collection grant activities, as well as help support development of the new Texas Sickle Cell Disease Registry. And so I'll pass it on to my co-presenter, Prashant, so he may introduce himself as
Yes.
well.
Thank you, Victoria. Yes, my name is Prashant, and I'm one of the senior business analysts for the Texas Sickle Cell Disease Registry that we're working on for Texas.
Yes, thanks so much, Prashant. And so we have a
Yeah.
few other team members on the call today. Dr. Heidi Boyes, who is the director overseeing the Sickle Cell Data Collection Grant and the Sickle Cell Disease Registry. Josiah Biggs, who is our legislative liaison. Gary Harwood, who's a project manager for the registry assessment. And then also Santosh Kumar, who's also helping support the registry assessment. Next slide, please. So we'll start by sharing a recap of information shared at last month's call about the Sickle Cell Data Collection Grant and then the Texas Sickle Cell Disease Registry. After the recap, we'll share the proposed registry opt-in process. And after, we welcome any feedback from you, the community, about the proposed opt-in process, and we're happy to answer any other questions as well. Next slide, please. And next slide. So the Sickle Cell Data Collection Grant is the State Health Department's current effort at examining sickle cell disease data in Texas. This grant is funded by the Center for Disease Control Prevention, also known as the CDC. Through this grant, we are working towards gathering health information from multiple sources to help determine how many people live with sickle cell disease in Texas and to better understand their health and healthcare needs. So data obtained through this grant are used to support policy decisions and resource allocation at the state and federal level, with the goal of improving and extending the lives of those living with sickle cell disease. Next slide, please. So the grant currently works with teams across 16 states. These 16 states represent about 50% of the U.S. sickle cell disease population. And of these 16 states, only 2 are authorized by their state government to implement a state sickle cell registry, and those states are Florida and Texas. Next slide, please. And next slide, thank you. So let's see. I think we might have a couple of slides missed, but that's a-okay. Let's see, we can start there, no problem. So the Sickle Cell Disease Registry, starting with the grant, has been very helpful for our team by allowing us to apply what we've learned to help shape the new Texas Sickle Cell Disease Registry. And the new Sickle Cell Disease Registry in Texas is mandated by the Texas legislature and does require consent of an individual to opt in before their health information is included in the registry. Next slide, please. So the registry and grant do have some similarities, but there are notable differences. The data for both systems are secure, published information is not identifiable, and both serve the same purpose of informing sickle cell practices and policies. The registry, however, is a continuous project, whereas the grant is a one-time effort. The registry is authorized by the Texas legislature, and grant activities are authorized by the agency's Institutional Review Board. Of course, more resources.
Do you mind just emphasizing that concentric circle area that specifically says published data is aggregate and not identifiable? Elaborate. That has come up, and I want to make sure that it's explained to the community that their identity will be de-identified.
Yes, absolutely. And so any information that's published and made available to the public, all of that is aggregate in nature, which essentially means there's no individual line of information. No individual records will be shared, and then everything is de-identified. So if you go to our sickle cell data collection grant, you can see some examples of the reports that we have made available, and all of that is aggregate, so really summed and not at the individual level. And it's de-identified. So all information is kept secure, confidential, and none of that information will be shared with the public. Any identifiable information remains secure within the registry database.
So no employer can go to this database and find out if a person has sickle cell disease and use that to not hire them. That's a scenario that's come up.
Oh, yes, correct. So anyone who is not authorized access to the registry will not have any information within that, right? So only the data stewards, the data owners, which will be the Department of State Health Services in Texas, will have access to that information. And even within the agency, it's limited to a very small group of individuals, and that's those who are maintaining the registry itself.
Okay, thank you.
Yes, of course.
Great question.
But yes,
And then I can
go for it.
go ahead. Okay, perfect. I'll take over from here. Thank you, Victoria. Again, as part of the registry assessment, our objectives are just to conduct an environmental scan of existing sickle cell disease registries in other states, and then to also engage stakeholders who will use the data to help us, inform some policies and healthcare practices in Texas. And then some of the outcomes that we're looking to get out of this is we're just going to build and establish an informed community-driven sickle cell disease. And so to your question about can employers or can legislature get some of that information, as we mentioned, they can't. So that's some of the discussions that we wanted to have with you. So that's great that you asked that question. And then, this will help us better equip for proposing appropriate IT solutions for the next legislative session. So that's great as well. We have current sickle cell registries. We have Florida, Louisiana, Nevada, South Carolina, and Virginia. And then obviously Texas is going to be the next one that's coming along. These are just the current ones. And this is the list of all of them. And something I want to point out is if you look at the consent model for all of these, um, all of them except for South Carolina are opt out. So as we can see, the opt-in model is not a very used model. That is the model that we're going to use in Texas. And I'll give you a little quick information on that as well here. So the consent for registries, we have opt-in and opt-out. So the opt-in is basically we have to go to each patient and ask them, hey, would you like to participate in our registry? We have to get their consent before they can be included in our registry. As in, when it's opt out, the consent is assumed by law that we collect their health records and we would just have a database of all the patients. And as we move on, we'll notice that the Texas Disease Registry is actually going to be an opt-in registry as of the legislature. So we'll going to focus on the opt-in process for the Texas Sickle Cell Disease Registry. Now, this might be a little small, but I'm just going to walk through this slowly. And if you have any questions, please ask because we want to get your feedback on the consent process. So the first part of this is we're going to get patient information from newborn screening and electronic health records. We're going to have just sort of, like their first name, last name, and some of those details just to be able to identify who we're able to find who has sickle cell disease and see if they've consented based on the consent process that we're going to have. So we're going to have that. We're going to enable patients to be able to provide their consent, whether they provide it via mail, they do it on a web portal, so that way the case finding database will basically track the consent of patients as we capture their consent. From there, what we'll do is before we send any information to the registry, we'll go through sort of a process to figure out, okay, one, has the patient provided consent? So if the patient has provided consent, we want to make sure that their decision and consent is opt-in. If it's opt-in, then any of that information for that patient will, as you can see, this arrow will go directly into the registry. So that's like the easiest portion where a patient goes online, submits their consent, says, I would like to, participate in the registry. They said, well, I'd like to opt in. We can take their information and move into the registry. Now, the second part is, yes, they did provide a consent, but they provided an opt-out decision. Now, the opt-out could happen in the first place where they're like, I just don't even want to be part of the registry. So we would basically delete their data. Now, if the patient has never been in the registry, then we wouldn't obviously not be able to delete their data, but we would always check if they've opted out to make sure that there is no data for that patient in the registry database. And if there is, we would delete it. So that's basically the first process if they've provided any sort of consent. Now, if they have not provided any type of, do you have any questions on that? I want to make sure we're clear on if they provided consent and the process we're following there.
I definitely have a question, and I
Okay.
want to just make sure I remind everyone you are welcome to put your question in the chat or come off mute and ask your question. This is a very informal, open space. And I also want to acknowledge Carol's Promise, who is the co-host for tonight's session. Thank Kenya Buckley of Carol's Promise for inviting her network in, who represents the Dallas-Fort Worth area. So we're spreading the wealth tonight. But the question, and thank you for acknowledging this tiny text on the screen.
Yes.
And so, look, so I come to this with a DRPH in public health. So that should tell you a whole lot about how I'm thinking about this. I just feel that giving people the option or needing to opt in kind of sets us up to not have good comprehensive data. I can't be the only one that makes that assumption. And I'm just thinking about the pockets of rural Texas that may have sickle cell represented there that may not even, we're trying to reach them. We're planning to get into every crevice of Texas just to get them to ask these questions or listen to me ask these questions. But Is there any possibility to eliminate or flip to from opt in to opt out? And if so, what does that involve? I can tell you that at the listening session that we had on Saturday, the legislator that sponsored the bill not only said that she was going to seek an opt out, she was also going to seek adding sickle cell trait to the registry. So could you just speak to
Yeah.
those concerns?
Yeah, that's a great point, right? We would like it to be opt out as well, but this is a registry this is a legislative decision that's been made. And Josiah, maybe you could chime in on this
No, I mean, I think,
legislative.
yeah, no, I'm happy to step in here. I appreciate that. No, I mean, I think if the member was on here who wrote the bill, and that's just how that's going to have to be. Like, this is the statute does say that it's an opt in, and so in order for that to change, that member or some other member of the legislature is going to have to change the statute. But if she's already come on here and said that she's willing to do that, we have a legislative session coming up here, so to be
So for
continued.
now, what I'm hearing for now, it is going to be opt-in
Yes.
until the legislative member actually gets the mandate changed. So
But
Dr.
again,
Perez, it's good. Yeah.
I mean,
Go
I
ahead.
would, with anything with the legislature, I would want a level set because that is a whole process. Like, again, so many things can happen. But if, yeah, in order for it to become opt out or what all y'all are looking for in those kinds of changes, it will take a legislative change. And that's a huge process. And again, lots of things can happen. Just because a member says that they want to do something doesn't mean that it'll necessarily get done. Hopefully it will. But the legislative process is very complicated and a lot of things can happen. Again, something simple like this is, again, I don't want to speculate too much. Something simple like this probably stands a decent chance of going forward. But it depends on a lot of factors. So.
Thanks so much, Isaiah. And so what we can do for now, while it is an opt-in element for the registry, is really focus on that provider and community education. So helping raise awareness about the registry, what it means to be a part of the registry, what that opt-in process is, and really partnering with our providers, our community-based organizations, to help educate, the community and to help garner support and interest in joining the registry.
Nicole's question speaks to that. Is this up to our sickle cell disease provider to offer us to opt in? That's one question. And does the current bill include capturing information for sickle cell trait? That's another question.
Yes.
Right.
So it does. Oh, go ahead,
Oh,
Victoria.
you're good. Go for it, Prashant.
I was going to say the sickle cell trait, right now, as part of the mandate, we're not capturing. We're only doing sickle cell disease. And it is not up to anybody to do it other than the patient. They can do it on behalf of the patient. But maybe let me walk through how we plan to do the outreach itself for patients who have not provided any consent that we find may have sickle cell disease. So let me do that real quick, that process. So if we find out the patient hasn't provided consent, right? What we'll do is we'll mail them an initial letter and we'll say, hey, look, this is the program we have. Would you like to participate? And then we'll wait for some sort of confirmation. And then we have a 30-day waiting period. We'll contact them again. And this could be via email, via mail, as well as, a phone call, text, etc. And then again, 15-day waiting period after that second attempt. We'll go to a third attempt for the patient as well. And then we'll wait one last time for a 15-day period to see if they have a response. If they've provided a response, we'll document that response in the case finding database where we'll say, okay, this person has given the consent. Since they've given the consent, we'll be able to take their data, move it into the registry database. And if we don't get any response, then basically what we'll do is we'll sort of take that data and say, okay, look, we didn't get any response. We'll reach back out in 1 year to that patient. Now, that patient could give us a response, and that response could be an opt-out response. And if that's the case, and they're not in the database, in the registry database, then obviously we won't do anything with their data. That's the process that we have for the outreach. And then again, that's how patients and their data would move into the registry database based on getting their consent.
And you're finding out that this patient exists by provider data.
By yeah, we're using newborn screening and electronic health records data.
Okay, that's all my questions. Please continue.
Yeah, so that's all we have for
Oh,
the
okay.
consent process.
Okay.
We wanted to make sure that this consent process, where we're attempting to reach the patients and getting their consent, you don't have any concerns, or if you have any other things that we could maybe add to this or anything else, we're just trying to get feedback from you and the rest of the folks on the call.
Well, I will say that when people are able to ask questions and really understand this process, then, they start, waking up. And, Marketing 101 says they need 18 impressions in order for it to start sticking. So I don't know if we got 18 times to be together, but I'm going to try as much as possible just for people to have an understanding of what this is. Like, I didn't even realize that there was a legislative bill and this grant. And if you don't mind, what did you say that the two states, one of which was Florida, what was that distinction they did?
Let me go back up to right here. So these are the two states that have implemented a sickle state registry, which is going to be us, and then as well as Florida.
Oh, okay. Okay. And
Yeah.
Florida, I know, is not only collecting trait data, they also are opt out.
Opt out. That is correct. They
Mhm.
are opt out.
They have majority newborn screening data, but how can newborns can't consent? I mean, obviously parents can, I mean, but they're opt out, so it's automatic
Mhm.
consent. So but just thinking about the community-based organizations, the patient advocates, those that want to be counted, because we're looking at this as if we know where the patients are, we know that if it's enough patients, then that could warrant more resources. I do see a hand raised. That could warrant more resources, more centers of excellence. I'm referring to centers that specifically treat sickle cell. um, and the only way to know that is to know the actual numbers of people that are affected. And if we have this opt in, that to me, that sounds like a threat. However, I'm also told that there's going to be the first ever Texas Sickle Cell Day at the Capitol. And I can tell you that the As One Foundation is definitely going to be in those halls meeting with, those legislators to try to implement this change, but also, get the bill funded, because I understand that it's not funded where it needs to be. So all of that, I'd love for us to continue to talk about. But I see Miss Linda's hand raised, so you are off mute. You're off mute, Miss Linda. Go ahead and ask your question.
Okay, Tamia, you know what we're doing. First of all, my name is Linda Chandler Jacobs, and I am the founder and the executive director of the Potter Smile. What we are doing right now is we are going to start testing with a DNA sequencer, but we're only testing for sickle cell disease or the sickle cell trait. And I was talking to the lab on Monday, and I was telling them about the registry, and I said, we have to figure out how we can work with the register, because when we start testing, we have a large amount of our population that do not know their sickle cell status. So one of our goals is to get these people informed about their sickle cell, to find out if they have sickle cell disease or the sickle cell status, and to educate them, get them referred out for help. So we plan to launch this in September. So how can we correlate with you? Is there some way? I was talking to the lady at the lab, and she said, yeah, we can definitely correlate, but I'm pretty sure we'll have to follow some type of process. Do you have any idea of how that might could work?
Yeah, that's a
That's a good.
really great
Thank you,
question.
Victoria. Go ahead.
And so what we can do is once we get closer to start implementing the sickle cell disease registry is we can have materials available that you can then provide to folks who are receiving these diagnostic testing. Information about, what is the registry? What are the benefits? How do you opt into the registry? Once you're in, what can you expect? And so we can provide those educational and outreach materials so that you have someone come in, get tested, find their status. Here's some information on the registry. And so I think that's something that we can definitely do and to help smooth that process of referring folks to the registry.
Yeah, because I told her that's the main thing we definitely want
Mhm.
to do. And since I have sickle cell trait, we will probably try to keep up with the percentage of people with trait until we can get it okayed for Texas. So, but we definitely want to participate in that because those numbers will be so instrumental in getting us more funding and the help that we need with the actual um, process. And we hope to launch this at our symposium in September. We always have this big symposium at Wheeler Avenue Baptist Church. It's an all-day symposium, but the goal is to launch that DNA sequencer at that September. We're going to start in Harris County, and if everything goes correctly with our funding, we're just going to start going state by state. And Tamia will be a part of it, and she and I both will be in Austin and in Washington, D.C., trying to get more attention brought to this disease. I like to call it a disorder, not a disease, but
That's really
Any,
exciting. Thank you so much for sharing, Linda.
Yeah.
thank you. Any other questions or comments? That our timing is pretty darn good. So you guys have ESP as well as being good data folks. So with that said, we have Marcelo, who is on the call. You are a co-host. As we said, SCALATE stands for Sickle Cell Across Lived and Treatment Experiences. And we hear curative therapy, disease modifying therapy, all cures, miracles, all the things. Marcelo will introduce himself and tell us about one of those tonight. And certainly, we'd love for you all to remain because I think they're kind of hand in hand with affordability, access, all, Texas is the home of the largest medical center in the world. And unfortunately, we still have access issues. We have patients in Katy that have access issues, and Katy is technically a very affluent area. But when it comes to sickle cell disease, Texas does not rise. Everything is not big in Texas when it comes to sickle cell, and we want to make that true. So, Marcelo Vargas Baños, please take it away.
All right. Thank you, Tamia. So it's a very amazing pleasure. It's a pleasure to be here with you. So as Tamia stated or mentioned, I am here to tell you a little bit more about the treatments for sickle cell disease and go in depth about gene therapy, right? And I think it's equally important to really discuss or talk about the accessibility component, right? I heard, the acronym for SCAPE, Sickle Cell Across Lived and Treatment Experiences. Experiences entailed accessibility, it entails knowledge, it entails understanding what is there out there for the warriors, for the caregivers as well. And I'm here to, just be able to disseminate that information. I'm an educator. I'm working in the capacity of patient and community educator with genetics. And I want to be able to go ahead and share my slide deck. And if you have any questions after what I will be sharing with you, please feel free to, just go ahead and come off mute and ask the questions, right? I'm here to answer any of the questions about, the therapies, the gene therapy, and also about accessibility as well for gene therapy. Okay. How does that sound? Is everybody okay with that?
That sounds good. And you are a co-host, so you have the ability to share your slides.
Wonderful. All right. Let me see.
And everyone, please feel free to put your question in the chat. Come off mute, as he said.
Yes, just a second.
Dr. Heidi said, spreading the word at community sickle cell events is a great idea. Oh yeah, and we certainly plan to play a big part in that. Speaking for the As One Foundation, but we do quite a bit of collaboration. You heard from Miss Linda and others.
All right. You're gonna have to tell me if you can see my screen.
Oh, you can see your screen.
Okay, wonderful, because I'm not able to see you. All right. Okay, so again, thank you so much for being here, and I want to thank you, Dr. Tamia Austin, for having me here. I understand that knowledge is power. Understanding about sickle cell, understanding about gene therapy, the treatments, it is empowering. It's empowering to the communities, empowering to the warriors, to the caregivers, to everyone. Okay. So my name is Marcelo Vargas Baños, and I come to you from the beautiful state of New Jersey. We call it the Garden States, the Garden State. So it's Eastern time right now for me. I think it's if I'm not mistaken, 8 o'clock for me, it's 7 o'clock for you, for your folks in Texas. And yeah, so the my purpose here is to just be able to disseminate as much information as possible. And this presentation is about Lyfgenia, which is a gene therapy for sickle cell disease. And as I mentioned before, I am a patient and community educator with Genetics Biotherapeutics. And know that this information is for US audiences only. And this is about education, okay? It does not replace doctor's recommendation or any doctor's suggestions, right? So I just want to make sure that that's out there. All right, so that's a long, very long paragraph. Note that this is what is essential. I'm here as an educator. I'm here to talk about the treatment options for sickle cell disease. I will, cover sickle cell disease because I think it's equally important to level the playing field for everyone here, as well as, go in depth about the advanced treatment options such as gene therapy, talk about gene editing, gene addition, and going into depth about Lyfgenia, which is gene addition. Okay, so here's what we are going to be covering in this presentation. I will tell you a little bit about genetics biotherapeutics, talk about understanding sickle cell disease, go in depth about Lyfgenia, talk about some important safety information for Lyfgenia. I will cover the clinical study for Lyfgenia and the results, some patient support services. As you know, sickle cell disease affects everything. It's not just the diagnosis. It affects it is a disruption to your life, to your work, to everything. So what is genetics doing regarding that as well? And I will also cover some of the Lyfgenia treatment journey, plus the eligibility process. And last but not least, some Q&A and also additional resources. Okay, so at Genetics Biotherapeutics, we are really trailblazing new paths in sickle cell disease. We understand we have a deep sense of purpose and partnership with community-based organizations, as well as getting information from warriors. Warriors are so important. They got to be at the center of everything. And we are dedicated to advancing therapies to help transform what's possible for people living with sickle cell disease. So I want to go ahead and highlight three things here for this slide. The first thing is that we are building on our commitment to building on our 10 plus years of sickle cell gene therapy research and community partnership forward with new breakthroughs in sickle cell disease. Gene therapy is really all we do, by the way. We don't do anything else. Continuing progress through experience. dedicated to ongoing learning from every patient, every trial, to really improve on sickle cell disease treatments. And lastly, the commitment to patients and families. So as I mentioned before, sickle cell disease is not just about the diagnosis, it's about everything else. It affects everything. So we're here to provide the support that never ends to caregivers, to warriors. And we have comprehensive help with, travel, lodging, transportation, access, and all the resources for patients and families in every other step of the way. All right, I understand that many of you know about sickle cell disease, but I just want to make sure that we really level the playing field here, and just for everyone to be in on the same side, or just having to have the same information here, okay? So we know that gene therapy is a genetic lifelong disease marked by unpredictable progressive symptoms. Right to your left, right here, you have a normal red blood cell. Okay. And this normal red blood cell has a hemoglobin protein. This hemoglobin protein is a adult hemoglobin, or we can call it adult hemoglobin protein. All right. Uh, so to your right, you have a sickle-shaped cell. And what differentiates the sickle-shaped cell with the other cell, the normal cell, red blood cell, is that if you were to have a microscope and you were to look at the cell and the inside of the cell, you were to look at the hemoglobin, you were to see that that cell has a sickle hemoglobin, all right? Sickle hemoglobin. And that sickle hemoglobin, if you were to go farther than that, look into the genes, you will see that there is one gene, it's called the beta globin gene. And in sickle cell, that beta globin gene is not functioning properly. Okay. And that's why somebody who has sickle cell disease is making sickle hemoglobin. And as a result, they're making also sickle red blood cells. All right. So to your left, a normal cell, that normal cell is making adult hemoglobin. Right. And it just doesn't have sickle cell. All right, now that we know a little bit more about sickle cell, I want to go ahead and talk about some of the treatment types for sickle cell disease. There are three commonly used treatments for sickle cell disease. So I want to highlight the three of them. The first one is the disease-modifying therapies. And these are the therapies that really manage the day-to-day symptoms caused by the disease. So for instance, we have hydroxyurea or L-glutamine, right? So they manage the symptoms. It could be also pain medication as well, right? So they offer some relief for pain crisis. Right in the middle, we have the stem cell transplant. So this is the bone marrow transplant. Now, some differences between this and gene therapy is that bone marrow requires a donor. Okay, it requires to find somebody else, find a sibling or find a family member, and really match with that family member. And we know that that is difficult. That is hard. That's why it's not really for everyone. And it's recommended for patients under the age of 16 as a one-time treatment. Now, to your right, you have the advanced treatments such as gene therapy. Now, remember, so I said one difference between bone marrow and gene therapy. Bone marrow requires a donor, requires somebody else. Now, for gene therapy, it's really your own cells. So your own stem cells. So essentially, it does not require a donor, right? You are your own donor. That's the first thing. The second thing is that obviously, in similarities, it is a one-time treatment, right? It's a one-time thing. It's not like you you take it today and then you got to go back the next year and then the next year and the next year. No, it's a one-time thing. And it has the potential to eliminate or reduce sickle cell crisis This is VOEs, or vaso-occlusion, vaso-occlusive events, including pain crisis. Let's dive a little bit more in detail on gene therapy. So gene therapy for sickle cell disease. There are two types of gene therapies that have been approved by the FDA for sickle cell disease. They both use your own cells, and they really do not require a donor, right? You are your own donor. So the first one is gene editing, and the second one is gene addition. What is the difference, you may ask? Okay, well, for gene editing, specifically, this is targeting, or is actually focusing on a part of your DNA that is switching off the fetal hemoglobin production. Okay, and let's not be confused with fetal hemoglobin is not adult hemoglobin. Let's not be, that's a difference. Adult hemoglobin is what you make when, essentially every person makes adult hemoglobin if you don't have sickle cell disease. Now, fetal hemoglobin is what you make after you are born. As a newborn, you start making fetal hemoglobin. Everyone makes fetal hemoglobin. But the issue is that you stop making fetal hemoglobin at a certain time. And then if you don't have sickle cell disease, you will make adult hemoglobin, right? But if you do have sickle cell disease, you will make sickle hemoglobin. All right. That is the path. That is the reason. That is essentially what happens. So in gene editing, what they want to do is they want to go ahead and tell the DNA, a part of the DNA, hey, do not stop making fetal hemoglobin. Go ahead and make fetal hemoglobin, right? We know that fetal hemoglobin, obviously, if you make more fetal hemoglobin, you're not gonna, essentially, it's gonna essentially help you with the sickling, with the vaso-occlusive events. So yeah, so that prevents sickling, right? Now, to your right, gene addition. In gene addition, we're not changing anything. We're not telling the DNA to make fetal hemoglobin. That's not what happens. What happens is that, I don't know if you remember that I mentioned that if you were to look at in the microscope, you were to look at the cell, you were to look at the sickle cell, you see the sickle hemoglobin, but inside that sickle hemoglobin, there is a gene, it's the beta globin gene that is not functioning properly, right? That's what I mentioned at the beginning. Now, for gene addition, guess what? We're going to be adding that gene back into your cell, but that gene is actually going to start functioning properly. That gene is actually coming back and is going to be functioning now. And guess what's going to happen? So if you have sickle cell, right, and that gene is not working, right, and that's why you're making sickle hemoglobin, and that's why you're making sickle-shaped cells. Now we're going to gene addition, which is Lyfgenia, and we're adding the gene that is actually going to be working and back into your cells. What do you think is going to happen? What's going to happen is that instead of making sickle hemoglobin, you are going to start making a version of that adult hemoglobin. That adult hemoglobin that I don't have sickle cell disease, so I'm making adult hemoglobin. So that adult hemoglobin that somebody who doesn't have sickle cell disease is making. And as a result, you're going to start making normal, rounded cells. And remember what the whole purpose of this really is. The whole purpose is to stop or reduce sickle cell crisis. Now let's focus on gene addition. Pardon me for a second. I don't know if I can move this. Okay. Sorry, I'm just trying to fix my screen. Okay. So gene addition, as I mentioned before, is Lyfgenia. Lyfgenia is the commercial name, but essentially it is gene addition, okay? It is a one-time gene addition therapy, right? It happens one time, and it works at the genetic level. Okay, so Lyfgenia has been studied for over a decade. In fact, it's the longest for an approved sickle cell disease gene therapy. And I want to highlight three things here. The first one is that you do not need a donor. You are your own donor. The second one is that it is for patients 12 years and older with a history of sickle cell crisis or VOEs. And it works using a well-studied delivery system to give your cells new instructions to make working hemoglobin or adult hemoglobin that does not sickle. And what is the purpose? Well, the whole purpose is to stop or reduce sickle cell crisis or VOEs. Okay, let's talk about sickle cell crisis. Let's talk about VOEs. So, a sickle cell crisis or vaso-occlusive event is essentially a painful event that happens when sickle red blood cells block the blood flow. And of course, this is known as a vaso-occlusion or vaso-occlusive event. And Lyfgenia, in their clinical study, they looked at both a VOE and a severe VOE. And let's take a look at the difference here, okay? So a VOE was defined as an episode of acute pain from a blockage, okay? A vaso-occlusion, a blockage lasting more than 2 hours, right? And the warrior is at the hospital, right? When that happens. And there was also other things such as a blockage in your lungs, which is called the acute chest syndrome, right? Or blockage in your liver, the hepatic sequestration, acute hepatic sequestration. And last but not least, blockage in your spleen, acute splenic sequestration. All those things happening, lasting more than 2 hours. Now, that's VOEs. Now, let's take a look at severe VOEs. This was defined as an episode of sickle cell crisis lasting more than 72 hours. And some of these warriors were receiving IV medications at each visit, right? And there were also other instances of priapism and requiring any level of medical attention. Okay, so I want to go ahead and emphasize or highlight this slide here. Remember, sickle cell is not just about the diagnosis; it's about everything. It's about the effects that is what is actually causing in your life. It's disrupting the daily, activities or going to school, for instance, or work or family, right? All those things. It's also, essentially um, causing you to go to the hospital a lot, ER visits and hospitalization, all those things, okay? It's not just about the diagnosis. All right. So just want to tell you a little bit about how Lyfgenia works at the genetic level. So
Can we just take a breath and ask if there are any questions?
yes, of course. Are there any questions so far?
And are you going to get into cost? Um,
I will,
or,
I
or,
will
or
cover, yes, I will cover some of that accessibility component. Yes,
okay.
absolutely.
In
Um,
8 minutes, right?
yeah, I will be as fast as possible. That's
Okay.
why, yeah.
Okay.
Any questions? Or can we leave the questions for the end so I can give you the information and then you can ask me the questions that, you might have. Does that sound
Sure.
okay?
Sure.
All right. So Lyfgenia works at the genetic level. So it is gene addition. So it's adding back the gene, right? The beta globin gene. So what happens is that the first thing that happens is your blood stem cells are collected. The second thing is that once the collection happens, in the lab, your stem cells are modified. So they're adding back that beta globin gene that is functioning, that is going to be functioning. Then step number 3, I think, is the toughest one because here's where you receive chemotherapy. And remember that chemotherapy, it is for your bone marrow, so it creates a space in that bone marrow, so the new cells that are actually coming in, it has the space for those cells that are coming in. Okay. And also know that for other treatment options, such as bone marrow transplant, that there's also chemotherapy as well. So this is where Lyfgenia is infused. Now, the last thing that happens is that once it is infused back in you, you create red blood cells with working adult hemoglobin. And where's the whole purpose? The whole purpose is to stop or reduce sickle cell crisis. Okay, so I want to go ahead and actually tell you a little bit about some important safety information that you need to know. So this is during clinical trials. We're talking about before FDA approval. Um, this is what it's essential to know. So there were 3 patients that were diagnosed with blood cancer, and 2 patients were treated with an earlier version of Lyfgenia using different manufacturing processes and transplant procedures. So what does this mean, really? So in the clinical trials, before FDA approval, there were different manufacturing processes for Lyfgenia and also transplant procedures for Lyfgenia. Okay, just know that those are not the transplant processes and manufacturing processes that are used now, currently, and also the processes that are used for what is the Lyfgenia that is commercial out in the market. And if you want to know more about this, just let me know, in the Q&A, as well as, I have some information for you. You can scan the QR code that I have for you in this presentation as well, so you can read more about it. And I will say that, if also equally important to talk about this with your healthcare provider, right? You want to know about the benefits, you want to know about the risks, you want to know about everything, right? It's equally important to talk to your healthcare provider as well. Okay, so as I said before, Lyfgenia is the longest study-approved gene therapy for sickle cell disease. This is some of the information. There were 45 people in the study. The median age was 25. The range was from 12 to 43 years old. But the Lyfgenia that is out in the market, the indication is for patients that are 12 years and older. So there's no cap in the upper age range. And the median duration of the clinical trial was 42 months. So here's the clinical trial really quickly. Just note that, this is one study. This is called study 1. And essentially it is divided in arms. There's arm 1A, 1B, and 1C. And in those arms, you can also see the amount of people in each of those arms, as well as, you can also see protocol changes here happening. And this is where I was telling you about. So I was telling you about the protocol change. I was telling you about the different things that actually improved in the product. You can see there were 2 protocol changes between study 1A and study 1B, and then another one between study 1A or 1B and 1C. So we also assess safety. Safety is assessed throughout the whole study, and efficacy is assessed in study 1C. Okay, so note that the Lyfgenia that is out in the market today is from the results of study 1C, the 36 individuals, as well as the ongoing study. So this is what I'm talking about. So study 1C. Okay, so one thing that, if there's one thing that, you should actually get from this presentation is this slide here. I think it's one of the most important slides. So the reason why it is important is because it shows the history of the warriors, the patients going through the process, the clinical trial, the before and the after. Okay. Right in the middle is where Lyfgenia gets infused. All right. So before, this is the before, to the left. All right. Each horizontal line represents a patient. Okay. And each of these dots represents sickle cell crisis. Okay. And we defined that. We said that, there was sickle cell crisis lasting 2 hours, and there was severe sickle cell crisis lasting more than 72 hours. So the severe one is the gray dot here. And the other crisis is the clear dot or the white dot here. So as you can see here, each of these warriors are going through crisis throughout the months, right? Before Livgenia, each of them. Right in the middle is where Livgenia gets infused. And right after this is the amount of warriors going through crisis. So as you can see, there is a difference. You know, the amount of people going through crisis after and before. All right. So I asked warriors, you know, what would it mean for you not to go through crisis, not to go through, VOEs, you know, and some of the answers um, are wonderful. They say, you know, life changing, the world. It would mean getting on a plane and just, you know, going somewhere, right? All those things that could potentially cause crisis, right? And you see the difference here. You see the difference. All right. So very quickly, I know we got we don't have enough time, but I want to go ahead and tell you what the treatment journey entails really quickly. So the first thing that happens is that pardon me for a sec. The first thing that happens is that step one, the pre-treatment happens. So what does that mean? It means that, you know, this is where you get assessed by your healthcare provider, or also you go to the hospital that is nearby you and just get assessed. And it is not only about Lyfgenia, but they assess to your overall health as well. And for this, essentially, what happens is that, you know, the healthcare provider tells you if Lyfgenia is good for you or it might not be good for you. There might be another treatment option as well. Okay. Let's say for sakes of this presentation, you're given the green light. So the second thing that happens is the stem cell collection. And this takes approximately a week at the hospital. We call it QTC, which is the hospital. I don't know why this is changing. All right. And essentially what happens, this is where your cells are collected, okay? And the third step is Lyfgenia creation. This is where the gene that I was telling you about, it's added back into your cells, okay? And this step takes about 10 to 15 weeks. And know that you don't have to be at the hospital for this step, okay? You can go home and be at home for this step specifically. I know step 4 is the hardest one, in my opinion, because it involves conditioning and chemotherapy. Okay, and know that, you know, remember that it is to make a space for your bone marrow for the cells to come in again. And this is why it is equally important to really talk to your healthcare provider about some options. Let's say you're a young warrior, you're considering starting a family in the future. What is out there for me, you know, for you in this case, if I want to do that? We understand that chemotherapy has, you know, a probability for to affect fertility, right? So what are things that are out there for warriors? Well, I can tell you from our own company, we do have a fertility preservation program, and we offer that. Okay, so that means
Can
that
I'm Marcelo, I'm going to just cut in. And we are 1 minute overtime, but I don't want to end. I know you have more to say, but if you don't mind, I would just like to let people sign off if they need to sign off, and I will remain as long as others remain, so that you can finish. And if people are definitely interested and have more questions, but I don't want to hold people beyond our normal time. So if you need to leave, please go right ahead. If you have a question, come back and review the YouTube. Um, and I'm going to allow Marcelo to finish.
yeah, and I promise I'm not gonna make it long. All I can say is that we do have a fertility preservation program, so feel free to reach out. I will leave my contact information as well if you have any questions about that. But know that that is available. Okay. The last two steps are essentially step 5 is where Lyfgenia gets created, and it is actually a bag. It could take 30 minutes per bag at the hospital. And essentially, that's where your body has room for the new cells. So you will receive Lyfgenia through an IV infusion. Okay. This could take approximately 1 to 4 bags. The last step is the recovery and long-term follow-up. This could take approximately 3 to 6 weeks of monitoring at the hospital at the QTC. Okay. And there's a follow-up, a long-term follow-up for 15 years. Okay. At least 15 years. And yeah, so the last slide here, just to wrap up, are the services that we have beyond Lyfgenia. We understand that fertility is very important. So that is something that we have as part of the whole support group service. And this is, just essentially finding, just that service if you're interested and connecting with the patient navigator in this case. We have 3 patient navigators in this department. You will connect with one of them and they can help you with that as well. And also we have another service. It's called the peer-to-peer support, which, if you want to know from somebody who has gone through the therapy, right? There are questions about, what was it like to go through the therapy? Were you concerned about anything, or were you thinking about anything, or what were your questions? So you want to know that they can connect you with that, as well as finding what are the hospitals that are nearby as well. And yeah, and you can scan the QR code here, and this will take you to the enrollment process. This is just for you to get these services, okay? Yep. And remember, so no donor needed. Lyfgenia is a one-time gene therapy. It is for ages 12 years or older with history of sickle cell crisis, and it's designed to help your body produce working hemoglobin that can reduce or stop sickle cell crisis. And with this, I want to go ahead and end my presentation and open the floor for Q&A.
Well, the one question I have is, I know you said 12 and over, but is there any level of, well, two questions. Um, is there any age that is too old, or can a person have been too sick to be able to do it?
Mm-hmm. That's a very good, very, very two good questions. So the first one is that it is indicated for 12 years and older, and it might be up to the hospital, right? They might have their own specific policy, right? And procedures when it comes to, gene therapy, right? There are some hospitals that have a cutoff, right? When it comes to age.
Mm.
And also, for the second question about being too sick, for instance, to go through the process. Yeah, that is also considered at the during the first step, which is the pre-treatment, right? They want to be able to assess everything and see if you can actually go through the process. Sometimes that might be one of the limitations. It might not be your age. It might be just basically if you can handle the whole process. And let me say this about that. We know that sickle cell affects everything, right? It affects organs, affects bones, affects everything. And as time goes on, it continues to affect that. So we have to take into consideration all those aspects as well.
So just to follow up, and because I have, these wonderful data folks here for the state of Texas, and we are talking about a registry for the state of Texas to be able to know all of the warriors affected. And our goal, of course, is to be able to get to them to make sure proper resources are allocated. How does this work together? How does knowing we have um, a disease modifying therapeutic gene addition, that's probably not the, cheapest thing to do, but it is available. But how does a registry and having and collecting the data that's going to be collected through the registry and the grant work together to, is that possible? I mean, maybe this is for you, Marcelo, maybe this is for Victoria's crew.
Sure. So I can answer from my side, I guess, very limited I guess answer, but then Victoria could possibly expand on this. So from my side, I think, in the state of Texas, unfortunately, there are some, there's a scattered number of patients everywhere, right? Warriors, when we talk about, let's say, Houston, we might understand a little bit more about that, but if we go to Dallas, that's a different story, right? So, knowing where the cluster of community members are living will essentially provide more information on where they're accessing the hospitals, the QTCs, right? And if that happens, they can also know where these hospitals are, closest to their where they live, right? So if that happens, they can actually understand, or in this case, provide accessibility to more information, or where they could go if that's the case, right? So I think having a registry will provide a lot more understanding on, first of all, where are the patients? Second of all, where these patients are accessing based on their proximity to medical centers or hospitals or all these things. And third, I will say, and because of this, we could potentially say that if there is an activated hospital in, let's say, Houston or Dallas, we could potentially say, you know what, this is good information, so we can work with those hospitals to try to get more education to those patients that now we know are close by.
Victoria, did you have something to add?
Yeah, thanks so much. And so we will be including a component. So when folks opt in, or they submit their decision about whether to be within the registry or not, we're thinking about including an option about, let us know if you want to sign up for general information from the registry team, right? And so this could include information on, very general information about available therapies, maybe like news and updates that might be relevant to the sickle cell community.
Mm.
And so that's one way that we can help share information with the sickle cell community, and just let folks become aware of what's available out there.
Okay.
Mhm.
Well, I thank you. I thank everyone that stayed 10 minutes beyond time.
Yes,
Um,
thank
is there any other final words from any of our speakers, our guests, any of our participants? Please feel welcome to come off mute and say so. Again, a hearty thank you to Carol's Promise of Dallas Fort Worth, our co-host for tonight, and all of those of you that hung in there with us. On behalf of the As One Foundation, I see no one coming off mute. I see no hands. I see
I
nothing.
came off of mute. I wanted to ask a quick question to the um the drug company. I'm sorry, I'm having a senior moment. It's still dread. Now, which lentiviral vector are you all using for your blueprint? Are you all using that HIV-1, or do you know?
That's a very good question. Hold on, let me show you. Hold on just a second, because I do have a slide for that, but just, those questions are not typically asked, but you know, but we do have a slide for that. So I want to be able to show you with the slide.
Miss Linda, do you mind putting your email in the chat and maybe Marcel can directly email you?
He
Well,
knows.
that's
He knows
as
my
well.
email. I
Oh,
mean, it's
okay.
going to
Yeah.
take up much
You
time.
can
I
you
can
can
I
later.
want I want to give people their night back.
Yeah. So essentially, it is a lentiviral vector. It is, the reason why this is well studied. It's one of the most well studied lentiviral vectors for the HIV. But let me highlight this. It is a blueprint, okay? It is the blueprint. It's not going to provide or give, it's not going to give you HIV, by the way, okay? It is the blueprint. And the reason why this is imperative to say is because the blueprint, what it does is a vector. It takes that gene, the beta globin gene, it takes it back into your cell. So it is efficient at doing that, at bringing that genetic material back into your cells. All right. And just very quickly, that's kind of like the process. Think about it as an envelope. A vector is like an envelope used to deliver genetic material. So the lentiviral vector does not include parts of the virus that cause HIV. Okay, it is built only using the parts of the HIV that are good at delivering the genetic materials to your stem cells. And this genetic material is basically the beta globin gene that they're putting back, and they're delivering that back into your cells.
Okay, thank you.
Yeah.
Okay, anybody else? Thank you all so much for your time. We will be back on the third Thursday of the month next month. This is the fourth Thursday, but since we were so close to Juneteenth last week, we decided to push it to the fourth Thursday. But we meet here for Escalate every third Thursday. Please follow the As One Foundation on all social media platforms. And this session will replay on our YouTube channel. With that, thank you all for being here. We will see you next month.
Thank you
Thank
for
you,
having me.
Dr. Aston.
Thank y'all so much. Take care.
Thank you. Bye.
Bye-bye.